The question was about probiotics for treatment of inflammatory bowel disease. Of course, there's been a great deal of interest in this field, mainly based on animal modeling, which suggests that there are beneficial bacteria that can be given. But I don't think it's going to be that simple in man. I find all the data in human disease to be quite disappointing, except in pouchitis, where possibly VSL number 3 may be beneficial reproducibly in a couple of studies. But even then, we don't know which of that combination of 8 different things, what's the real probiotic agent. I think it's naive to think that you can just give a single bacteria and establish a toehold and really have it change the inflammatory state of a patient. We're not mice. We're not all genetically the same. Probably the genetics suggests that we're very heterogeneous. When we talk about Crohn's disease, we're talking about probably 10 different things. So I wouldn't know which probiotic agent would be beneficial for which patient. So at this point, I view it as harmless, but I don't know that it's beneficial for any patients right now.
You think one of the concerns I have about using biologics early is the burn rate. I find that it's relatively rare for one patient to stay on the same biologic for more than 5 or 10 years. 10 years is really not the limit. When you're
It is because they've only been around for 10 years.
But a majority of patients by an extended period of time have lost effect. And it may be the way we're doing it, but if you're starting somebody on a biologic when they're 18 and we burn through
Absolutely correct. And that's why I raised the issue that maybe you could start an immune modulator early, where even there, even if it isn't because of antigenicity, you can see loss of response to those over time as well. And the other factor that we were talking about this morning is the acceptance of patients of early aggressive therapy. They are new to the disease. They have no idea what's coming in the future. You as a physician can see further down the horizon what may be coming for the patient. That doesn't mean the patient is going to believe you when you tell them, if you don't take this strong therapy, something bad is going to happen in 2, 3, 5 years. And that, I think, is also where disease prognostication can be helpful. If you can more clearly say to a patient, look, we've done studies based on your profile of whatever, genetics, environment, serology, you have a 90% likelihood of needing 2 surgeries within the next 5 years. That could be more convincing than just the doctor saying, I think you should go on this. All those are concerns and potential impediments to early thank you, everybody. If you fill out your forms,